Can you hear okay?
Sorry about that. That was mine.
Oh, you do? Okay. But we found with our own data, the guys we treated in 1986 and 87 with brachytherapy, which is radioactive seed treatment, the cure rate was pretty mediocre. We were still learning how to do the procedure, and plus a lot of the guys at that point had not been screened, so they had more advanced cancer. And then just a couple years later, 87 to 89 or so, the cure rate went up pretty dramatically, and that was because mainly we got through our learning curve on how to do brachy because nobody was doing it in the world with ultrasound guidance except for the three of us at that time. And by 1998, once everybody was screened, people with the same Gleason score, the cure rate was dramatically higher. And so that showed that the screening effect allowed us to catch guys with lower volume disease. So even if the Gleason score was the same, the volume disease was less, so the cure rate was better. You guys see the slides yet?
Yeah.
Okay.
Yeah, but we only see the first slide.
Okay, let's click through. Or can I drive that there, David, with the mouse? Click through the slides. Thanks. All right, I'm right-handed here, so I'm gonna put this over this way and see if I can adjust the slides here on the bottom. We'll just go. There's some screening stuff. See, the death rate dropped pretty dramatically when screening started, 45% actually in the United States, thanks to PSA screening, so it's critically important. Lymph node invasion went down. Our cure rates in Seattle went from a low cure rate when we're learning how to do Cs up to a medium cure rate once we learned how to do Cs to a high cure rate once guys are PSA screened. And even though this is guys were treated way back in 1998 to the year 2000, 9 years after treatment, 92% had no evidence of disease. That is still better results than modern radical prostatectomy or modern IMRT or SBRT or hypofractionated radiation, still dramatically better results. So newer is not better, necessarily. So right now, these are the FDA-approved options for the treatment of localized prostate cancer. There's external beam radiation, which is intensity modulated radiation, or stereotactic radiation, stereotactic body radiation therapy, or proton beam therapy. There's all types of external beam where you lay on the table and the machine treats you from different angles. Brachytherapy, which can be radioactive seeds, which is called low dose rate. Now, not low dose rate, or HDR, which is high dose rate. The actual dose of LDR is higher than HDR. It's just the seeds stay in there forever and they lose half the radiation every 2 months. You get a higher total dose. Both of these treatments were started by my partners and I in Seattle in the 1980s. And we did that because they gave a higher dose of radiation. The HDR, we used to treat 100 guys a year with HDR and 600 a year with LDR. And then we found at 5 years the cure rates were the same. But at 10 years, the LDR had a better cure rate, so we stopped doing the HDR. Some centers do HDR. HDR does have a better cure rate than IMRT or SBRT or protons, but it's not higher than LDR. Cryotherapy, freezing the prostate, is FDA approved. Radical prostatectomy is approved. Open or robotic doesn't really make a difference, although 99% of the guys get robotic. Active surveillance, watching it, doing PSAs every few months and biopsies once a year or so is an option for low-risk patients. Those are guys with Gleason 6 disease, PSA under 10, usually only a few biopsies positive. HIFU is not FDA approved for prostate cancer treatment. So I know guys have talked about HIFU at this meeting and other meetings, but it was found neither safe nor effective for prostate cancer twice by the FDA. It's approved for use of prostate conditions, but not approved for prostate cancer treatment. It has a low cure rate and it has significant toxicity. So twice the FDA voted on this. They found it neither safe nor effective. So it's not approved. That's why if you get it done, you got to pay $20,000 to $40,000. And then there's a good chance you're going to see me or somebody a few years later for treatment of salvage treatment.
Is that the same as focal therapy, which is sort of an ablation technique also?
Yeah, it's a type of focal therapy, but you got to realize ablation means destroying the tissue. But HIFU just treats little burns, and so you got a cold spot between the burns. So even though you can identify the dominant intraprostatic lesion on an MRI scan, and you can burn the heck out of it, you still got cold spots in there, and you have really high recurrence rates. And so they play these tricks with their publications, and it's very frustrating. But like they just had another publication saying they had a good success rate, but they decide success as not having Gleason 7 or higher biopsy on subsequent biopsies. They don't define it as a relapse-free survival, meaning the PSA goes low, number stays low. They don't even define it as not having Gleason 6 cancer. They just say they don't see any Gleason 7 or higher. And even with that, they're still having 30% recurrence rates with Gleason 7 or higher, and they call that successful. But with Gleason 7 breakthrough, we've got only an 8% recurrence rate. So it's not successful, and unfortunately, it just doesn't work well. Prostate cancer is multifocal. So you could see the dominant lesion on the MRI scan. You could do saturation biopsies, which we do all the time. I did 2 this morning, where we do 26 to 50 biopsies transperineally, put like 8 needles into the dominant lesion, biopsy the rest of the prostate. And it's not uncommon at all for the primary lesion on the MRI scan to be Gleason 6 and us to find Gleason 7, 8, or 9 elsewhere in the prostate. And if you did HIFU or focal therapy, you only treat the area you see, and you're missing the area where there may be more disease. And then you got a mess to deal with in the future, because the guy's got recurrent disease, and you're dealing with a scarred prostate. Sometimes they have urethral strictures and other things. Sometimes they don't have any side effects hardly at all, but they're out $30,000 or so. So bottom line, approved therapies are external beam, brachytherapy, cryo, and radical, and not many people do cryo anymore. So external beam, the machines look like this. You can do SBRT, which is stereotactic body radiation therapy, which is 5 treatments. You could do standard fractionation, which is 39 to 45 treatments, or hypofractionation, which is 20 to 28 treatments. Most people do 20 to 28 treatments. For low risk and intermediate risk cancers, that's pretty much standard of care. SBRT is still a little bit experimental. We are doing we did 2 randomized trials on this. One is NRG-005, where guys are randomized to the 5 treatments versus the 20 treatments, 28 treatments. The other trial is 5 treatments versus 5 treatments. I'll get about that later. SBRT in the small pilot studies they've done so far looks like it's working as well as external beam radiation. Not quite as well as brachytherapy, but as well, maybe a little better than standard external beam, but has not been proven in a randomized trial. And a lot of stuff becomes apparent when you do a randomized trial. So that was NRG-005. That was just completed. We're the only NRG site in Southwest Florida, outside of Moffett. So I treated patients on that protocol. That protocol is now closed, but the Boston Scientific SBRT protocol with spacer is open. The other way is radioactive seeds. These little pellets we put in the operating room under general anesthetic. It takes 15 minutes to do that. We go transperineally, so the needles go through the skin, not through the rectum, the skin between the scrotum and the rectum. So the risk for infection is extremely low. Like one guy, we had no serious infections out of 12,000 patients actually in Seattle. So this is really cool. External beam therapy uses multiple beams. We usually use close to 200 now. Then, high dose of radiation is the red area, which is the prostate. The blue area is very, very low doses of radiation. You have to realize we live on a radioactive planet. Our bodies are used to being radiated every single day. Thousands of times a day you get radiation, damaging your DNA, and your body repairs it, just like breathing. Your body does this normally. The trick is not to give too high of a dose to a too sensitive a structure. And in this area, the rectum, which is right below the prostate, is a more sensitive structure. In the old days, radiation went right through the rectum. Nowadays, we can make the radiation actually curve around the anterior rectal wall, and you can get a lot higher dose to the prostate that way and lower dose to the rectum. So that reduces side effects significantly. Now, interrectal balloon is a balloon that is placed, it's a little tube, rubber tube about the size of my finger that we lube up and we slip in the rectum, we inject air into it, and that blows a balloon in the rectum. See, you got the tailbone here, the rectum, the prostate, and the bladder right here. Because what happens, there's a study I did in Seattle in 2007, there's a thing called Calypso, which is 4-dimensional real-time external beam radiation. It was developed in Seattle. I was their advisor along with my partner, Tim Make. Tim was the first guy to do HDR in the country. But if this is the prostate and this is the beam, we do a CAT scan before we turn the beam on to get the prostate lined up where it's supposed to be. That's great. But then we push a button and the machine starts treating. It takes about 3 to 5 minutes to do the treatment. And what Calypso did, it showed us what the prostate was doing 20 times a second while the beam is on. And what we found is while the beam is on, everybody's prostate moved out of the beam partially. The prostate's moving up and down constantly because you've got gas going from the sigmoid to the rectum back and forth constantly, which makes your prostate move up and down. So one way to stop that, and that is you put the little tube in, you inject air that blows a balloon up in here, it holds the prostate still. So the whole time the beam is on, the prostate is in the beam. The other thing it does is it pushes the rectum, the back part of the rectum, down into the dark blue area, so less of the rectum is getting moderate doses of radiation. Matter of fact, most of the rectum is only getting low doses. So the studies out of Europe, where they have longer follow-up with the rectal balloon, shows that you get less side effects. Not only do you hit the cancer better, because the prostate's in the beam the whole time, you treat less rectum. So, but that came about based on the study we published on the Calypso in 2009. And then starting 2010, 11, 12, we started doing the balloon. Actually, the company that makes the balloon for the main company for the whole country is in Tampa. I helped design the most recent version of the balloon. Unfortunately, nobody south of Venice or north of Lakewood Ranch, West Bradenton, uses a balloon. I've talked to guys at Moffett about it. I've talked to guys at Fort Miles and neighbors, and they don't do the balloon. They should, but they don't. So they're starting to do a little bit of it in Inglewood and Port Charlotte, but they haven't done any patients yet.
What do they use?
They don't use anything. They just let the prostate move out of the beam. Yeah, it's a little frustrating. Okay, the latest advance for radiation beam treatment is something called SpaceOR. And I guess I got the slides a little further down. I get to that. Calypso we talked about, prostate motion we talked about, brachy we will talk more about, but this is what the brachy looks like. I'll get to space for a bit. When you're asleep in the operating room, up at the ultrasound probe in the rectum, a metal grid goes on the probe, and the needles go through the grid, through your skin, not through the rectum. They go through the skin, so it's clean. We drop the seeds off. So this guy's got 2 needles up here, and you can see the seeds right here. 2 needles here, the seeds here. 4 needles here, the seeds here. Top to bottom. This is a slide I use for training doctors on how to do this. And then, of course, at the end, you got seeds everywhere. It takes less than a minute per needle. Each needle's got like 4 or 5 seeds put together. So that was started by us in the 80s. We've done over 12,000 patients, about 7,000 actually being done by myself now. We've done lots since I've been here. We're going to look at effectiveness trials, and you got to base it on risk groups. A lot of people ask what your stage is of prostate cancer. You don't really go by staging for prostate cancer. You go by risk categories. Because staging does not include the Gleason score, which is critically important. It does not include your PSA, which is critically important. It just goes by the rectal exam. So a low-risk patient is a guy with a PSA under 10, a Gleason score of 6, or in other words, less than 7, and a rectal exam that feels normal or just a small lump. Intermediate risk, a PSA between 10 and 20, and or Gleason score equals 7, and or entire one side of prostate feels abnormal. And high risk is anything worse. PSA over 20, Gleason score 8 to 10, both sides of the prostate feels abnormal, and you feel in some less worse. So when you compare results of one treatment over the next, you got to make sure they got the same amount of intermediate risk in their studies, for instance. Or you're comparing intermediate to intermediate risk, not intermediate to low risk, because otherwise it'd be apples to oranges. So this is a slide I used, and the results really haven't changed over the years. to train physicians how to treat prostate cancer. These are the results of the top centers in the world, not just average centers. These are the best of the best. And you got radioactive seeds here, you got surgery here, you got external beam here. I put HIFU and cryo down here so you see what they got. Now let's take intermediate risk, which is the most common disease we see. That's a Gleason 7 and or a PSA between 10 and 20. And see, Memorial Sloan Kettering, the biggest center in New York City, 5 years after treatment, 89% of the guys are alive with no detectable disease. So when we talk about success, we're talking about not just alive, we're talking about alive with no detectable disease, PSA 0.2. Cleveland Clinic, 89%. The first guys we treated in Seattle, we had an 80% success rate, 15 years of follow-up. Then I looked at the guys that we treated from 98 to the year 2000. At that point, the seeds were stranded. People were doing PSA screening, and we were past a learning curve. At 9 years after treatment, 91.9% had no detectable disease. So it's long follow-up, very high cure rate. HDR, which is the temporary seeds, Demonis does a lot of it at UCLA. He's retired now, but basically he did a lot of it at UCLA. He had 87%. So it's good, and it's higher than beam, but it's not as high as seeds. And see, for high risk, with the seeds, we have 86%. This is a multi-institutional study of Cleveland Clinic, UC San Francisco, Mayo Clinic. They all trained under us in Seattle. And they had 86% success rate for Gleason 8 and higher cancers, which are bad cancers. HDR was 63%. So don't be confused. HDR is not high dose. It's high dose rate, not high total dose. Surgery has lower success rates because surgery does not treat any cancer outside the prostate. And prostate cancer is frequently microscopically outside the prostate. So the top center in Europe is Hamburg, Germany. They got a 66% success rate. Mayo Clinic in the US is 65%, Hopkins 76%, Cleveland Clinic 79%. High risk is even worse. The higher the risk, the higher the chance it's outside the prostate, so the lower the cure rate with surgery. Okay, external beam therapy has a 87% success rate with 7 years of follow-up. And if you do, there's a misprint here. I just got screwed up a little bit.
94%.
Yeah, the 94% is wrong. I don't know how that happened. I just redid these slides after a red-eye flight, so that is incorrect. Anyway, we'll fix that later. Anyway, protons was published at 69%, but that was a misprint. They didn't do their math right, so in a letter to the editor, JAMA, they said the real success rate was 79%, which is more accurate. CyberKnife, they had a 93% for low risk. They now have some updated data at about 86, 87% for intermediate risk. And HIFU, this is the top center in Europe doing HIFU. The most modern patients are at 63% success rate. And this includes multiple HIFU treatments. This is not just one treatment. Some of these guys got treated 2 or 3 times, and that's their ultimate success rate. Cryo 61%. All right, so that's kind of a lot of details there. There's a more intuitive slide that covers everything right here. And this is a study done by Dr. Grimm and I in 2009 and updated in 2012. And on the website, Alex C., a friend of ours in Seattle, keeps updating it more. But bottom line is we took all the studies published over a 10-year period of time, got rid of all the bad studies. And these bad studies are studies that have less than 5 years of follow-up or less than 100 patients. So this, again, is relapse-free survival, alive with no evidence of disease, at least 5 years out. And let's get to low risk here first. Here's low risk. So at low risk, remember, low risk is really early favorable disease, so the likelihood the cancer is outside the prostate is smaller. And so surgery, which is red, does okay with low risk disease. See that? There's a lot of overlap between surgery and seeds, which is blue, and the beam, which is green. So for low risk disease, whether you do surgery, external beam radiation, or seeds, the cure rates are really good. You know, there's some trends, yeah, maybe a little bit better with seeds than the others, but not dramatically. So for low risk disease, you definitely want to pick the treatment that's going to cause the least toxicity, and that's going to be individual. So if you got a guy with a small prostate and no urinary symptoms, he's a younger guy, you probably want to use seeds. Because it's got a higher dose of radiation than anything else. If you got an older guy or a guy with a bigger prostate with moderate symptoms, then the beam therapy is good because it causes less temporary urinary side effects than the seeds. If you got a guy who had prior radiation because of rectal cancer or something in the past, then surgery is a reasonable option. So you got to pick and choose which guy. But in terms of alive or dead, 99% of the guys can be alive. In terms of relapse-free survival, they're all pretty good. But you guys starting to get worse disease now. You go to Gleason 7 or a PSA of 10 to 20, there's a higher chance of cancers outside the prostate. And when that happens, surgery plummets. Because surgery doesn't take care of cancer outside the prostate. So look at surgery. It's fallen in this, Hopkins, 76% success rate, Cleveland Clinic, 79%. But look at 10 years, it's down to like 65%. Remember, seeds, we were up at 92% with 9 years of follow-up. And some more modern studies are even higher. So with the seed data, which is the blue dots, or the black squares, which is beam and seeds, you got very good success rates. External beam alone is a little bit lower because it's a lower dose of radiation. Again, the beam is good at taking care of stuff outside the prostate and killing most of the stuff inside, but doesn't always kill everything inside. And notice also the trend. The trend with the beam is downward as time goes on. The surgery is definitely a downward trend as time goes on, but the seeds is flat. The guys are either curable or they're not. And if you do the beam and the seeds, the chance of cure is very high. What about high-risk guys? Here we go, high risk. Same thing. Blue stars, beam and seeds doing really well. Surgery not doing well in 15 years. That's not good at all. If you do surgery for high-risk disease, there are some guys who do sometimes recommend it. The guy's got bad disease, big prostate, bad urinary symptoms, is otherwise healthy. Sometimes we'll recommend radical prostatectomy with planned post-op radiation to kill microscopic stuff afterwards. Unfortunately, there was a couple high-volume surgeons, one in particular in town, that will do surgery on everybody, but he never recommends post-op radiation on his patients. And that's a problem, because none of those guys can be salvaged. Most of the guys aren't like that, but one guy is. External beam is kind of in the middle here. So if you look here, though, this is the highest group, this kind of peach color or whatever. That's external beam, seeds, and hormone therapy combined. So that's another thing, hormone therapy. Now, there are a lot of randomized trials showing you do radiation therapy plus anti-testosterone treatment, because prostate cancer feeds on testosterone. 8 studies show that radiation beam plus the anti-testosterone treatment has a better cure rate than the radiation beam alone. 0 study that show hormones in surgery works better than surgery alone. The hormones doesn't help the surgery work better. Now, there's a big study done, a meta-analysis, and they looked at how long you need to do the hormones for. The hormones have a lot of side effects. Infancy, hot flashes, weight gain, blood sugars go up, muscle mass goes down, stuff like that. That's temporary, but still it's bothersome. If you do brachytherapy, you only need the hormones for about 12 months if you have really high-risk disease. If you do the beam without the seeds, you got to do the hormones for 2 years. So another advantage of adding brachytherapy in guys who are candidates for brachytherapy is that you don't need the hormones, you only half as long on the hormones. And then study from Mount Sinai, New York, said only 9 months. You might be able to get away with even just 9 months. So these are the success rates overall of the different treatments. HIFU isn't in the high-risk guys really at all in here, I don't think. We do have it listed here for intermediate risk, just out of curiosity. It was HIFU was a beige one. It was down at 60. It's covered up by something else. It was down in this area in here.
That's not it on the upper loop there, toward the center, that's on the gray line there?
No. Yeah, there was only one study. That was the European study. Okay, so low risk. So with low risk guys, there's the issue of active surveillance versus treatment. What should you do? And survival, the chance of being alive 10 years down the road is the same, whether you treat right away or treat later. And there was a randomized trial published in New England Journal of Medicine in 2016, where 1,600 guys were randomized to surgery right away, radiation right away, or watching it and treating it when the cancer got worse. And you know that because the PSA goes up or a repeat biopsy is worse. 99% of these guys did not die of prostate cancer at 10 years. But the chance of the cancer spreading elsewhere in the body was lower. In other words, you had a higher chance of being free from disease progression if you got surgery or radiation versus watching it. Remember, these are low-risk guys. So surgery and radiation beam work pretty much equally well for low-risk guys. But if you watched it, you had a higher chance it would spread. Now, you're still alive, but you have a higher chance that you're now on hormone therapy the rest of your life. Or when you do get treated, and most of these guys did get treated, these active surveillance guys, when they got worse, it's not low-risk disease anymore. So it's not seeds alone or beam alone. It's beam plus seeds, or it's beam and hormones. So it's multimodality therapy. You got more side effects too. So it's an interesting study. Basically, it kind of suggests that if you have a young, healthy guy, treating it sooner rather than later may be a good idea, so that you avoid the effects of hormone therapy and all that. But if you're an older guy who's not in good health, you could probably just watch it and die of something else instead. So, but the biggest part of the study I thought was helpful was the side effects. This is a randomized trial. The patients were chosen for surgery or radiation or watching it just purely based on a computer coin toss. So there's no cheating in this trial. And what you find is, in terms of needing to wear pads because you're leaking urine, before treatment, nobody's wearing pads. In the bottom left-hand corner, no one's wearing pads. But 6 months after treatment, about 40–50% of the surgical guys are in pads, and long-term, about 15 to 20% of surgical guys wear at least one pad a day the rest of their life. Randomized trial. This is factual data. Now, this is important. It's one pad or more. Nobody I know walks around wearing a pad in their shorts unless they're leaking urine. Unfortunately, a lot of surgical trials define incontinence as 2 or more pads a day. So one of the top surgeons in the country, Scardino, published a 14% risk of incontinence. No, he published less than 2% risk of incontinence defined as 2 pads or more. But then when he looked at his data and defined it as 1 pad or more, his incontinence rate went to 16.9%. So when you look at, when somebody tells you surgery is a good option for you, risk for incontinence is less than 5%, you got to pull them down and say, where do you get that number from? And you define it as 1 pad a day or more than 2 pads a day, and what document proves that? Because there's no data showing that that's true. That's based on 2 or more pads, not 1 or more pad. Now with radiation, there was no difference between radiation and watching it. There was no increased pad use in the guys who did radiation versus active surveillance at all. But radiation does not really cause incontinence. That's a surgical thing. A lot of guys will say, oh yeah, you get incontinence with radiation. It's extremely rare. Matter of fact, the active surveillance, which is the blue group, had a higher risk for incontinence 6 years after treatment than the radiation group. And that's because some of these active surveillance guys, remember, went on to get surgery, and that's why they leaked. It's not because the active surveillance made it. All right, erectile problems. Well, these guys are in their late 60s, so they're not having no problems. Here, better is 0, okay? They're not having no problems. Some of them, 20% or so, are already having problems with erections. But 6 months after surgery, 2/3 of guys can't have erections adequate intercourse, and long-term it's over 50%. With radiation, there was a little bump here in erectile problems, but that was because they did something they shouldn't have done. They gave hormone therapy to these guys, and it doesn't improve your cure rate when you're low risk. It just causes impotency. But then as the hormones wore off, they got similar to the active surveillance patients. So in terms of quality of life, surgery is worse in terms of sexual function, and surgery is worse in terms of urinary function, period. Proven by a randomized trial. And there's only one randomized trial, but this is a good one. It's 1,600 patients with over 10 years of follow-up. Intermediate risk. There's a ton of options for intermediate risk. This is my longest consult on a young, healthy guy with intermediate risk. Okay, there was a study recently published. It looked at survival. Overall survival, if you get brachytherapy, is higher than external beam. Remember, some of these guys have died of heart attacks and strokes. This is overall survival, not prostate cancer specific. But the bottom line is the brachytherapy patients had a better survival than guys who didn't get seeds. And then there's a randomized trial. The ASCEND trial combined intermediate and high-risk patients. And what they found is that if they got beam and seeds, 94% relapse-free survival with 7 years if you got beam and seeds versus 82% without the seeds, and 86 versus 71% for high-risk patients. So statistically significantly better outcomes. Randomized trial.
And that's a no reoccurrence on?
No recurrence. Yeah, this is live with no reoccurrence. Then what about super high-risk guys? You got these guys, we've seen a lot of Gleason 9 or 10 cancers ever since people stopped PSA screening. And so UCLA and University of Pennsylvania combined their data and they looked at their external beam patients, their surgical patients, and their brachytherapy patients. And they presented a big trial in Orlando about 7, 8 years ago. I was at the meeting. I go to most of the prostate cancer meetings, and it showed that the seeds did the best by far. And they never published it, probably because it was urologists who wrote the paper. So then what they did is they combined their data with 12 major academic centers. They included University of Michigan, Cleveland Clinic, Johns Hopkins, so 12 major centers. They combined all their data and Gleason 9 and 10 cancers. This is a huge study. This is published in JAMA. Only about one article out of 300 or 400 gets accepted in JAMA, so it's got to be high quality stuff. and they looked at the outcomes. And there's a study, JAMA, lead author, UCLA, my alma mater, and actually radiation oncology is the lead author of the study now. And here is distant metastatic disease-free survival. So this is the likelihood that 10 years after treatment, you do not have cancer in your bones. And if you did the blue group, which is the guys who got seeds, it was 88% chance there's no cancer in your bones at 10 years. If you did surgery or radiation without the seeds, it's 58. Huge difference. Incredibly statistically significant. If you got cancer in your bones, you're on hormones the rest of your life. And you only have 5 years to live, usually. Now, it's getting better with some of the treatments we have, but still, it's not curable. All right, cancer-specific survival. The likelihood you're not dead of prostate cancer. If you got the seeds, it was close to 90%. If you didn't, it was like 78%. Again, highly statistically significant. Surgery is not doing better. Surgery does not have the highest cure rate, no matter what you hear from the surgeon. All right, overall, so alive or dead for any reason whatsoever, the seeds are doing the best. Because with Gleason 9 or 10, your leading cause of death is prostate cancer, not heart attack or stroke. This kills people. #1 cancer killer of men that are non-smokers, period. Now, long term, they all die eventually because, I mean, nobody lives forever as far as we know, unless you're the Highlander, I guess. So that's the data in terms of cure rates. Now, what about side effects? You got to balance this. I'm not recommending seeds to everybody. And you don't want to be peeing all the time and have to outhouse everywhere you go. And you don't want to have a hole in your rectum. But you got to realize a few facts, that newer is not always better. Protons, first of all, proton's not new. It came out in 1987. And it has, as you'll see down the road, higher risk of rectal toxicity than external beam radiation on the biggest study ever published. Robotic surgery is not better than open surgery in terms of cure rates or long-term side effects. But you are out of the hospital quicker. You do have a little bit lower risk of bleeding, but you're under the anesthesia a lot longer. HIFU, we've talked about. CyberKnife actually has a little bit lower cure rate than brachytherapy. Maybe the same or maybe a little better than standard external beam. That's being studied. That's what the NRG 005 study was about. It just closed last month. We're not going to have results on that for 5 years. So stuff like that, I don't usually recommend you treat with that unless you're on a study, a national study. We are doing a national study. 40 centers are doing the SBRT trial, just opened, the newest one. And that myself and the guys at William Beaumont in Michigan have put 6 patients, 3 by me and 3 by them, on the trial. But more, University of Pennsylvania, others are going to join the trial soon. So when you look at intensity modulated radiation therapy, external beam versus protons, we saw that protons had worse side effects. And here's the slide. So at 4 years or 6 years after treatment, protons is way up here in terms of toxicity at 2 years. So let's say 4 years. 4 years after treatment, protons has got a higher risk, 8% risk of toxicity, compared to external beam plus seeds, which is a lot lower, or beam alone or seeds alone, which is lower still. Monotherapy has less side effects than combined therapy. That's why treating earlier is usually better than later. And this is not with spacer, which we'll get to later. So with seeds, the side effects tend to be obstructive. You got to pee more often. The prostate swells, it squeezes the tube you pee through, so you got to pee more often. So a guy with a big prostate and getting up 3 or 4 times a night on Flomax, probably not a good guy for seeds. Smaller prostate, only waking up once or twice a night, good candidate for seeds. The risk of needing a catheter temporarily is 6% published by me, 35% University of Washington. Everybody takes a medicine called Flomax or alprazosin or doxazosin. And these urinary side effects usually last about 6 months and then gradually go away. Valve side effects are rare. The beam therapy causes mild urinary symptoms. So the urinary symptoms from radiation beam is less than the seeds. So a guy with a favorable intermediate risk cancer is an older guy that has some significant urinary symptoms. I usually recommend beam rather than seeds. Risk for a catheter is virtually 0. But you can have more frequent bowel movements. If you do need to treat the lymph nodes because it's high-risk disease, you get some diarrhea about half the time. And some tiredness is not uncommon. You don't have to have it drive you there. You don't need to take any time off work. You do all your normal activities except you can't ride a bike. And these side effects,
Except for anybody said.
you can't ride a bike. Tony, no bike ride. That's because of spacer. Now, the day you finish radiation, you can celebrate and ride a bike. And that's because the spacer can squish from the riding on a bike speed. A recumbent bike's okay. You can ride a recumbent bike. That's not a problem. Most guys don't do that, though.
Bikers don't do that.
Real bikers don't ride recumbents. Yeah. All right, this is a study on some side effects of Memorial Sloan Kettering. And with them, rectal bleeding was 1.4% with beam and 5% with seeds. They do seeds a little differently than we do seeds here. They don't use stranded seeds, and the seeds can migrate a little bit, and they actually have a lower volume of patients. But once we started using spacer, these numbers went way, way down. I've only seen one guy with any kind of rectal problems with spacer. Grade 4 is 0. That means you need surgery. 0 patients either arm. Grade 3 means you need like electrocautery to stop the bleeding. That's really low. Urethral strictures, you need dilation of the urethra because it scars down. That is low with both. Surgery is 12 to 15%, by the way. 12 to 15%. Radiation is only, 2 to 2.5% risk stricture. These are some data from radical prostatectomy. 33% reported moderate to big problem with continence. And 33% also have major issues with sexual function after robotic surgery. At 12 months, 55% were back to baseline urinary function with surgery. Only 24% made it back to baseline function with sexual function after surgery. The newest way of doing seeds is a stranded seed where the seed itself is embedded in an absorbable suture. That was developed by Dr. Grimm, myself, and Blasco back in the mid-90s. It got FDA approved in the late 90s. So that way the seeds stay put. You don't pee seeds out anywhere. You don't need to strain the urine. With external beam radiation, the advances have been using image guidance with the CAT scan, using the balloon, playing with the CT and MRI, and using daily Viagra with beam or seeds. You take, if you want to protect your erection function, you take half a Viagra pill every day during treatment for 3 months afterwards. Proven in a double-blind placebo-controlled randomized trial to improve the chance you keep your erections. The guy who wrote the study I've known for years, John Mulhall, and he told me at a conference I saw right before COVID that for him, he would stay on the Viagra forever, or switch to Cialis, but take like a quarter pill, whether you're having sex or not. It just helps the function. This is a good comparative study that looked at quality of life with urinary function, bowel function, and sexual function. The higher the bar, the higher the quality of life. So you see the blues doing the best across the board. Well, the blue were guys with no cancer. They had no treatment. Of course they did best. In terms of urinary and sexual function, yellow did the worst. That's surgery. That's not surprising. Basically across the board, the black did the best. Those are the seed patients. But the external beam patients was old-fashioned external beam. It wasn't modern IMRG. With modern IMRG, the beam is every bit as good as seeds in terms of side effects. All right. This is that Viagra study. Basically, I told you about that already. Advances, we'll skip through that. We got SpaceOAR. These are proven advances in radiation. Rapid Strand we developed in Seattle. The rectal balloon was developed in a few centers, but the main center actually is north of Tampa. It makes it even though nobody north of Tampa uses it. MRI CT fusion is used on all the major trials we do now with radiation planning. SpaceOAR, randomized trial. I think we'll get to that. Actually, the first guy to get SpaceOAR was by myself and Billick here in Sarasota. And most patients on the trial were treated by myself and a guy named Mardonis up in New York. So as far as research goes, we do a lot of research in our clinic, actually more on prostate cancer than any other center in the west side of Florida. These are some studies we already completed, a combination external beam and cesium study completed and published. The TAC 385 was a randomized trial with the new oral, there's an oral hormone therapy called Orgovix you can take. It was a randomized trial. Guys took the shots versus Orgovix. I was the second lead recruiter to that study. We saw that the guys who took the pill had less side effects, but equal, if not slightly better, reduction in testosterone. And then a friend of mine, Neil Shore, did another study with that versus Lupron, found the same thing, but the Orgovix, the pill, the hormone pill, has a 56% lower risk of cardiovascular toxicity. And the guy's side effects, the hot flashes and everything, don't seem to be as bad. That's a good thing. So FIGO, which is a radioactive injection we do if they have metastatic disease to the bone. There's a national trial done in the United States to verify the European trial. A ton of patients on that trial were treated by myself and a buddy of mine down in Fort Myers. The J&J trial we just completed, that's a new oral hormone therapy, a third generation apalutamide combined with radiation, so that's completed. The SpaceOAR trial, that was a big one. It's still making a lot of news. It reduced the amount of dose to the rectum by a 25% reduction in dose in the RD70, which is significant. And that reduced GI toxicity, erection problems, and actually reduced some urinary side effects. We published more than 9 times. It's presented at all the AUA, ASTRO, and ASCO meetings. FDA approved in spring of 2015. It's become the standard of care if you don't have visible disease on an MRI scan between the prostate and rectum. Here's a picture of it. The original SpaceOAR was not visible on CAT scans. The CAT scan's on the left. And the radiation dose is yellow. It covers outside the prostate. It curves up around the rectum. The SpaceOAR is here. So you go over here to the MRI. See the SpaceOARs in white there? This is the first patient ever to receive SpaceOAR in the United States, a guy that Billick and I treated back in 2012 or 11, a while ago. The new SpaceOAR is visible on CAT scans. We use SpaceOAR View now in all the patients. Here's the side view. You see the rectum down here, the SpaceOAR here, and the prostate here. So that means the radiation can be higher up and farther away from the rectum, so you get less side effects. And this is a spacer view. See, this is a CAT scan. When we do radiation every day, when I do beam plus seeds now, I do the seeds first. 5 weeks later, they come to the office under local anesthetic, inject the spacer gel, some gold markers, and then we do the radiation afterwards. And you can see the radiation beam is covering this area here. You see some of the seeds, and one cut, others cuts have them here and there. But see, the radiation is much farther away from the rectum than it would have been if there was no gel there. It's pretty good stuff for most patients. This is the results of this trial showing the guys who had the spacer had a lower risk of bowel toxicity and a lower risk of urinary toxicity for part of the time. Later studies showed a lower risk for impotency too. And then I was just at a meeting this last weekend, Saturday. I flew out to Denver for a national meeting. Flew back in a red eye Saturday night, Sunday morning at 12:30. Anyway, University of Pennsylvania looked on the guys who used the spacer, didn't use the spacer. 24% had grade 1 rectal side effects versus 12% with the gel. And grade 3, which is significant, was 2 versus 1. So the bottom line is the spacer does reduce side effects. TAC 385, again, the oral, it's called Orgovix now. It reduces cardiovascular side effects significantly and just causes less intense side effects.
That's a pill that you take, or what is that?
It's a pill. You take 3 pills the first day, then 1 pill a day after that. It was FDA approved about a year and a half ago.
Is that a follow-up to the radiation?
That's instead of doing the hormone shots, if you need hormones. Hopefully you catch this early as you don't even need hormones. But if you do need hormones, Orgovix is definitely the way to go if your insurance will pay for it.
When do you determine whether you need hormones or not at that point?
That it depends on how risky your disease is. So if you're bad intermediate risk or high risk, you need hormones, usually. If you're low risk or favorable intermediate, you don't. The tiebreaker is a genetic test called Decipher. And that was at 22 genes in the cancer cells. And if you have a lot of the bad genes and have a high risk Decipher, that is more important than Gleason's score. So if you got a Mayo way for that, Billick here in Sarasota and Castellucci and Bradenton send that on all their patients, and more the urologists are starting to do that. A lot still don't. So then when someone sees me for a consult, if you're Gleason 6 or 7, I usually have to have the pathology mailed to San Diego so they can run the test. And then we'll know whether or not you need hormone therapy or not.
When you say 6 or 7, is that 3 plus 4 or 4 plus 3? Or?
Doesn't matter. Doesn't matter. Yeah, because if you're 4 plus 3 on the Gleason score, but the Decipher is low risk, you don't need hormones. That's more important than the Gleason score. Matter of fact, we have a study, an NRG trial, that looks at Gleason 8 and higher cancers, and if you Decipher's on the lower side, instead of doing 2 years of hormones, we're dropping it down to 12 months. But you only get that if you're on the study. The latest study I'm most excited about is Advantage, which is a really cool study. We just completed it. It was written at Johns Hopkins. 40 centers in the country are invited to participate. 711 patients nationwide. It was for intermediate risk guys, and what we did, it was external beam patients, not brachy. But what we did is they'd come in the office and they're randomized to receive immunotherapy plus radiation versus radiation alone. Now the immunotherapy, I basically injected part of a herpes virus into the prostate. The part that's sensitive to the pills people take, valacyclovir, if you get herpes. And so that's taken up by the prostate cancer cells. And then during treatment, they take valacyclovir. And so the valacyclovir thinks their prostate cancer is herpes now, and it's attacking the prostate cancer while the radiation is attacking the prostate cancer. And the pilot study showed amazing results there were equal to seeds without the seed side effects, urinary side effects. So 711 patients treated nationwide, 115 were treated by myself up at Lincoln Ranch. And we completed the study in the fall of 2021. Unfortunately, the results will not be available for about 5 years. That's the way studies take. They take a long time. But that was a very cool study, which I think is going to be a game changer. Current studies, SBRT trial is using the 5 fractions of radiation with or without spacer. 2/3 of the guys get spacer, 1/3 do not. And we have several NRG trials NRG is the biggest research organization in North America. Major universities, Cleveland Clinic, William Beaumont, MD Anderson, and they invited me and the guys up at William Beaumont to do this too, because of all the prostate stuff we do. But it's very, very challenging to do. There's a lot of paperwork, but we're an energy site now. And those are the big things. The only other thing I'd recommend right off the bat before you ask some questions is that if you do get surgery, get your pathology report, the actual report. Because if you have extracapsular extension of disease, positive margins, or seminal vesicle invasion, you need to see a radiation oncologist to discuss whether or not you need post-op radiation. Because as I mentioned, there's a couple of high-volume surgeons that never send people for post-op treatment, although it's been proven in a randomized trial they need it.
You're saying get the pathology report as soon as the procedure is done.
Yeah, it takes a week or two to get it back, and then look at that, and then have a consultation with a radiation, not medical, but radiation oncologist. If you have one of those three things: extracapsular extension, positive margins, or seminal vesicle invasion.
Yeah.
Because unfortunately, one of the highest volume guys in town, he just shoots their patients up with hormone therapy every month if he fails surgery, which doesn't cure anybody and causes a lot of side effects. So, you guys have any questions or any questions about anything else?
A lot of information.
My mind is rattling right now.
Ready for a quiz?
Oh, no, I just, with this pandemic hiatus, I was waiting for watching posture. I had a single-digit PSAs and a 3+4 for my Gleason scores. But then just recently, within, I guess, 4 weeks ago, I had a more current biopsy, which was indicating 4 3s and 4 4s. And so,
Okay, you need treatment.
yeah, so that was very concerning. And like PSA was 9 at that point, 9.2 was, and so now I'm getting to the point where I'm going to have to pull the trigger one way or the other as far as that. So I was trying to determine which approach to take on that. So I'm right at that critical point right now. But of course, it's very stressful because I'm trying to avoid all the variables.
So you're high risk right here. So for high-risk disease, if you want to be cured, the highest cure rate is the beam and seeds, with or without hormones, depending on how high risk it is, how many needles at least 8. Surgery is way down here, and beam alone is down here. I mean, that's beam plus hormones. That's beam plus 2 years of hormones.
So for that posture, hormone therapy is also recommended.
No, see the black scars? That's no hormones. That's just beam and seeds, but no hormones at all. And the diamonds are beam, seeds, and hormones. There's a lot of overlap there. So we do not have proof that adding hormones to beam and seeds improves the cure rate. So most experts would recommend, if you have low volume, high risk disease, so like 1 needle of Gleason 8, 3 or 4 of Gleason 7, PSA under 10, use the 2 beam and seeds and no hormones. If you have a lot of needles of Gleason 8, or you have any Gleason 9 or 10, then you add the hormones.
Yeah, none of them have been they've all been 4 3s and 3 4 and 4 4. So and 3 over 9.
Would you do the Decipher test in that case?
Unfortunately, they don't allow Decipher on if you have Gleason 8. Now, we sometimes try to sneak it through, and once in a while, we succeed.
I have heard that.
And if we do succeed in that, and we see that Decipher score is more favorable, then that makes us that much more comfortable not doing any hormones at all.
And the Decipher score again is what?
A genetic test based on your biopsy.
Yeah, I did get a genetic test, I guess 2 years ago.
Yeah, anything that old is worthless.
Yeah, it would seem to me this Decipher thing, if you can do it, would add elements of knowledge that you don't
Exactly.
understand.
Yeah, exactly.
And you do that before?
Before you make a decision. Yeah.
And that would then tell me more of a depth of which direction to go?
Well, it helps you decide whether or not you need hormones. It wouldn't change anything on bean versus seed, bean plus seeds versus the bean without the seeds. It just mainly helps you decide if you need to add the hormones to the seeds. We know with the bean you have to add the hormones. We know with surgery the cure rate's low. With bean plus seeds, some guys do really well without hormones. Some guys maybe not so well. They still are doing better than surgery for the most part. Now, this was from Mass General. D'Amico publishes horrible results. I don't know what he does in the OR, but he's always got bad results. So these are, again, all the published papers, not just the good centers, but also some centers that aren't so good. And like surgery, you got to go to somebody who's really experienced with seeds if you have seeds done. Or any kind of radiotherapy, because it's a procedure you do. It's not just outlining something on a computer screen and let the beam hit that area. Any other questions?
What? Arnold.
You're muted, Arnold.
I have to unmute it, maybe.
No, you just push on your own button, probably
I
doesn't
think
do
you can
it.
do it.
You should be able to. Well, maybe not. Go ahead.
Usually the person has to unmute themselves.
Pardon?
How about now?
Yeah.
Okay, yeah.
Okay, Dr. Sylvester, Arne Prakau, you treated me back in 2018 with all the, basically at that point, I was a high risk. And I got the full treatment that you prescribed here.
Right.
And so after 2.5 years, my PSA was 0.2 for about 2.5 years. And then it started to climb up slowly, and then it ended up about 3 point something, and where the urologist said we need to do something. And so they ran an Aximum scan,
Right.
and found there was no cancer evidence in the prostate. However, microscopic and 2 lymph nodes in the pelvis area that they discovered. So they put me on a hormones treatment and shots and pills.
And what?
Oleada pills.
The Viagra pills and the hormones?
Yeah, hormone shots.
Yeah, hormone shot. Okay.
Yeah, and Oleada, which is I hope I'm saying it right. That's a 240 milligram once. I can't remember at the moment what the other name is, but laputamide or something like that. And I've been on that program for 9 months, and my immediately once the treatment started, my PSA went down to 0.01.
Right.
And my last 3 checks were 0.01, but basically undetectable.
Right.
And so would you still consider that I'm on the right track for?
Yeah, no, that's the right thing. What happens is, the cure rate's not everybody gets cured. Unfortunately, there's a new scan called a PSMA PET-CT.
Correct. Right.
There's the Oxman scan. That's a good scan too. And we weren't allowed to use those scans unless somebody failed treatment. Fortunately, now the new guidelines allow us to do the PSMA PET-CT scan if you have high-risk disease. So like you could do a PSMA PET-CT scan. And the advantage of that is there's going to be some guys where you're going to see disease like in a lymph node on that PSMA PET scan. And if we saw that when we treated you now, we would have done the same thing we did, but that lymph node would have got a higher dose of radiation. As a matter of fact, now there's something called oligometastatic disease. And so if you have metastatic cancer from the prostate in 3, it's technically 5, but the best results were 3. If you have 3 or less areas in your body, like 3 bones that have metastatic prostate cancer in it, you still treat the person for a cure. You still treat the prostate, the lymph nodes, but you also treat those bone lesions. And the bone lesions I usually treat with SBRT, the 5 high-dose treatments or 3 high-dose treatments. And randomized trials show that you improve your survival by doing that. And there's some data suggesting If you follow the person close enough, anytime a new lesion pops up, you buzz that, you may so deplete the cancer that it takes longer and longer for more lesions to show up that they may just die of something else before the cancer gets them. And you might be able to avoid or punt hormone therapy way down the road.
Yeah, I was prescribed to have this PSMA test. However, the ladies were explaining at the imaging center were explaining it to me if my PSA has not been rising several times in the last 6 or 9 months, and it's below 1.
Mine did, that's why.
Medicare will not pay for it.
Right, if the PSA is below 1, Medicare shouldn't pay for it because the scans are virtually always negative. So if a guy has surgery or radiation beam or radioactive seeds or whatever, and the PSA starts going up, we gotta just follow them until it gets to around 1, and then we can order this PSMA PET CT scan.
Okay, so should I get off the, after 9 months of basically undetectable PSA, give my body a break and then see what happens and then go back on if necessary?
You could do that. That's intermittent hormone therapy. Most guys will stay on the hormone therapy for at least a year before they go to intermittent. But you talk to your urologist, all different protocols for doing that.
Right.
Yeah.
But you feel comfortable I'm on the right track?
Yeah. No, that sounds right. The only thing to tweak, say you go off the hormone therapy, and then let's say 6 months to a year from now, PSA starts coming up again. And he does another scan and doesn't see cancer anywhere except for maybe in the lymph node area that already got radiation. See about going on Orgavix instead of the shots next time. Because that has a little bit less side effects. It's not, the cure rate, I mean, it's not a cure rate, but the response rate's good with the shots. It's just the side effects are a little bit worse for most guys with the shots.
Yeah, well, the biggest side effects for me are the hot flashes, and but I assume once I stop, if I stop the shots and pills, the hot flashes will subside, I assume.
They will eventually, but they take a long time to stop. They stop quicker after the pills.
Oh, okay.
Yeah.
Okay, all right.
All right, any other questions?
No, I appreciate you confirming everything.
Anybody else?
Is the PMSA test for a medium to higher risk? And
The PSMA PET CT scans approved now for high-risk disease or recurrent disease after surgery or radiation.
No, but would I get prior to treatment now?
If I should say anything.
Yeah, you could do it. You could do it now before you treat. It may help you decide on what treatment to get. Like if you do a PSMA PET scan and you see a couple of metastatic tumors, that drives you further away from surgery, more towards doing radiation. Not that surgery would have a very good cure rate anyway, because it doesn't. Andy, do you have a question?
A couple. When you're talking about the staging process and you're talking about the PSAs, we know the impact of ProScar. There's the question of doubling it, and then there's also some people talk about if you've been on ProScar for more than 10 years, do you further adjust? Do you have any thoughts about that?
Well, I definitely go by the doubling. The further adjustment after 10 years is like based on a very small number of patients. So, doubling I think is a good bottom line to go by.
Okay.
But the thing is, if you're on ProScar, so for several years, a PSA elevation of 0.4 is significant. So if you're running PSAs of like 0.7 or 0.6 on ProScar, and then you go up to, say you're 0.8, you're running 0.8 on ProScar, and then you go to 1.2, that's significant. If you're on
So just some, again, limited knowledge, but there's also a wide variation in PSAs from what I was looking at in studies in a given patient that can vary from 16 to 40 some percent with, when they did a study on a week to week thing. So, there's a lot, the question is that one test valuable, or is it really about trending? Or does it just depend on the clinical case?
There's less variation if you're on ProScar than if you're not on ProScar. But there are things that will make your PSA fluctuate quite a bit. Obviously, sex within a couple of days of your PSA blood test,
Yeah.
a long bike ride before the PSA blood test can affect it, an infection in the prostate can affect it. And there is a lot of natural swings in PSA a little bit, so you want to know the trend of your PSA too, not just one number. Like if I see a guy whose PSA is doing fine, he has one number that's high, I'm going to repeat that PSA before I do anything else. And it may just come down, it may have just been a lab error. It happens sometimes. It could be a fluke.
No, I mean, mine can vary significantly. It's a challenge. When you talked about the EPIC studies and the randomized trials between the radical prostatectomy versus the radiation, was that done in this country?
It was in the UK.
Okay, because I was like, Americans don't subject themselves to randomized studies like
No,
that.
there have been 2 big randomized trials, and it was the PROTECT trial.
That was UK. Did they talk about racial variation within that? Ethnic variation, or?
No, they didn't break it down by that. It was just based on overall numbers, but it's a huge study. And
Yeah, I understand, but there's obvious a lot of racial ethnic variation in this nation, and there is in the UK as well. I just didn't know if they, had better understanding from it.
Okay, well, that brings up a good point, actually. All the data on active surveillance, for the most part, is based on Caucasians. The little bit of data they've looked at on African Americans suggests that doing active surveillance on African Americans can be dangerous.
Yeah. Okay. When you talked about the Decipher score, what number, within that, what numbers do you consider low, intermediate, or high risk?
So intermediate is 0.45 to 0.59. High risk is 0.6 and higher. And very high risk is 0.85 and higher.
Got it.
Those are just kind of arbitrary points.
Yeah, no, I understand, because it's a combination of risk factors that they all want to add up, with the different.
No, Decipher is based purely on the genetics. Polaris and Oncotype uses your PSA and your rectal exam and everything, and Gleason score with their ultimate decision. But the Decipher is 100% based on the genes that they analyze, the 22 genes they analyze, their MRI genes.
I know I've had that done, and but I thought it also included your Gleason score in that, but it doesn't.
But you already have that. So if you got like a high PSA say 20, and your Gleason score is like 12 needles of 4+3, and your Decipher score comes back at like 0.58, that's technically intermediate risk on the Decipher score, but all these other factors.
3+4. Yes, but you only have 3.
So I would still feedback that more like a high risk guy.
Okay, and then the last thing, and I think I know the answer to this, but you were talking about, the better results with radiation versus surgery, even when it's not detected outside of even when the cancer is not detected outside of the prostate. Am I guessing that just from the sort of this, though you minimize this, the radiation outside of the prostate, you still get some of it, and that may be killing some of the cells that might be extracapsular or.
Yeah. So what happens when you do radiation, beam or seeds, you're treating the whole prostate plus about 8 millimeters outside the prostate.
Okay.
So when it spreads outside the prostate, it only spreads 2 or 3 millimeters.
And then when you say that, then the spacer is about how big, how thick?
It's about a centimeter, 10 millimeters.
Okay, so that's why. So it gives you a little bit more than that 8 millimeter kind of radiation.
And posteriorly, we don't do 8 millimeters. Posteriorly, we do more like 3 millimeters.
Yeah, but it just has that potential. Okay.
Because there's something called Dion's fascia posteriorly under the prostate that prevents cancer from going posteriorly. So when cancer spreads outside of the prostate, it's usually laterally or anteriorly or anterior laterally, where we can safely give wide margins. There's only fat out there. Posteriorly, fortunately, where the rectum is, there's this thick membrane called Dion's fascia that prevents cancer from going posteriorly, and that's this bad cancer. Yeah. So that we can get away with tighter margins posteriorly.
Any thoughts about significance of perineural invasion?
Perineural invasion is in some studies associated with a higher risk for recurrence after surgery, not so much after radiation, because again, the nerves tend to be on the outside of the prostate. If there's perineural invasion, that increases the chance of microscopic disease outside the prostate. And again, radiation treats outside the prostate, surgery typically does not.
All right, thank you.
Any other questions?
Can you hear me?
Yeah.
My name is Ed Virch. I live in Fort Myers. I recently had a PSMA scan this past Friday. And Monday, I spoke to my oncologist, who also works for Genesis Care. And he told me that I had a Gleason score of 3.4 or 3+4 initially, 7 Gleason score. And I've had 3 different radiation treatments. The initial was 45 treatments to my prostate. The second was 22 treatments to some lymph nodes that had shown activity on a PS or PET acumen scan, which I've had a few of, and some bone scans. The third one, I had 5 radiation treatments to my seminal vesicles, the precise ones, the higher dose.
Yeah,
And my PSMA is now at 5.8, and my PSA is at 5.8, and I had the PSMA scan, and it showed that it showed spread of just in my lymph nodes. He said there was no evidence of any metastases on the bone or any of my organs. So it's being recommended to me that I have the hormone therapy and Erlita, Eligard and Erlita, or Lupron and Erlita.
Or the pill, Orgovix and Erlita.
Orgovix.
Orgovix, yeah. So my first choice would be the Orgovix plus Erlita. That'd be a great option for you. If your insurance won't pay for the Orgovix, you can do Eligard or Lupron or Trelstar. Those are all equally effective.
But does it sound, I mean, have you ever heard of where it just goes in your, have you ever seen it with any of your patients where it just goes in the lymph nodes, but not to the bones or the organs?
Yeah, it starts at the lymph nodes. Eventually it may go to the bones, but it may take time. And it sounds like they did everything right. They treated the prostate initially. The 45 treatments, we don't do 45 treatments anymore, but that was years ago you had that done. Now we do like 28 treatments. But then when the cancer recurred, it recurred in your lymph nodes. And so then 22 treatments to 28, depending on what dose they give per day, is a pretty standard dose to give a big volume of lymph nodes. If you have a small spot in just like 1 or 2 lymph nodes, and it's not right next to small intestines, you could do further radiation to a couple lymph nodes. But if you got several lymph nodes involved in the pelvis and there's small intestines near there, you can't really give safely much more radiation. So going right to the hormone therapy would be the way to go.
He said I have several in my chest, stomach, and pelvis area.
Oh yeah, then that's
The lymphatic system.
you want to do the hormones. They cover your whole body.
So the hormone, in your opinion, your professional opinion, the hormone therapy and the Erlita is the best course of action.
Yeah, I think that's an excellent course of action.
Okay. But I mean, how's chances that it's in my lymph nodes and then a month from now it's attached to some of my bone or organ?
When you're on this treatment, it probably takes several years before it shows up in the bones.
Yeah. Okay. Thank you for that answer.
We have a lot of new treatments for that are very exciting, actually, that have come down the pipe. So.
Okay. Thank you very much, Doctor.
Sure, my pleasure.
There's great hope out there.
Yeah.
I mean, you've heard of Xofigo, I talked about briefly. That's a radioactive injection. When the cancer goes, like if you do this treatment, you are doing this treatment. Let's say 3 or 4 years from now, the cancer becomes resistant to this treatment, the PSA starts going up, they do a PSMA PET scan or a bone scan, they see some cancer in your bones. The next treatment then is going to be usually Xofigo, which is a radioactive radium that the radiation oncologists down there in Fort Myers, or us, we do it up here too, we give you an injection once a month in your vein. It has very little in the way of any side effects and attacks all the cancer and all the bones in your body.
Okay.
Has been proven to improve survival and improve quality of life. Matter of fact, the guys who got that treatment had less side effects than the guys who got salt water. It was a placebo-controlled trial. It was pretty amazing. And there's a new thing coming out called Lutetium-177.
Yes.
And that treats both soft tissue and bones. And so we did a study on that REASSURE trial I mentioned earlier. we had a bunch of patients I put on that trial. Well, some of those patients then went on to get the Lutein 177, and Dr. Sotar at Tulane and myself, his mother's published a paper on that recently showing that it's okay to give this Lutein 177 after you failed Xofigo.
Okay, yes.
So we have a lot of options available for you down the road.
Yeah, I read about the LU 177 and yeah, but it's apparently it would be the next step if the hormone therapy and Eligard doesn't work and doesn't keep it under control.
Yeah, you do that or Xofigo if it's just in the bones, but there's an advantage probably to you of doing the Lutein 177 because you got all this lymph node disease, and Xofigo doesn't treat the lymph nodes, and the Lutein 177 does.
Okay. Thank you very much. Thank you.
Wow, lots of information, my
A
goodness.
lot of stuff out there.
Dr. Buddha,
Yeah.
to prescribe the PSMA test, I mean, would my urologist do it, or?
You could ask your urologist to do it, yeah. One of the guys in town here.
Yeah, I'm coming up this week. I was supposed to get a CT scan and an AM scan, and is this a similar scan or should?
Nice guy.
It's
He's doing this for free.
the PSMA PET CT scan instead of the CAT scan, because it covers everything as a CAT scan plus this nuclear medicine on top of that. So it covers the bones and the soft tissue, and it's more sensitive than a bone scan or a CT scan.
Do you have to inject
An isotope.
an isotope?
And not iodine, it's a different radioactive isotope they put in called Polarify, and but there's usually a waiting list of a few weeks to get it.
To get the PSMA?
The PSMA PET CT scan, and Partners does it down here in Sarasota, and Simon Med does it up in Bradenton, and used to be Choice. So there's a few centers that do it.
Yeah, I was going to get the NM scan, and they Simon wants to send me up to Kissimmee to do the test. I'm like, oh, I'm surprised.
To where?
To Kissimmee.
Maybe that's for their standards. I don't know. Kissimmee by Orlando?
Yeah.
There's another place in Pinellas that we send a lot of patients to, international, whatever. But they get things approved pretty fast, pretty good.
But the PSMA test can be done here in Sarasota.
Oh God, yeah. Yeah, we used to have to send them down to Fort Myers, but and I mean our company has a couple of PSMA scanners, but I mean had guys drive all the way to Boca and then down to Fort Myers. But now that and we are going to get it in our practice here at Sarasota shortly. But in the meantime, Partners does a great job. Partners is great.
Yeah. Well, guys, I have to tell you, this has been a great session. My goodness. Not a lot of information, and we've got it recorded, so
Yeah,
if you
all right,
have any
very good.
questions.
Good.
But thank you, Dr. Sylvester, for a tremendously impressive presentation, and it gives us all hope. And you know that there are people like Dr. Sylvester out there exploring all these possibilities too. It's a constant part of his business, so keep in touch and thank you.
My pleasure.
Tony had a word or two he wanted to speak, but thank you, Dr. Sylvester, very much.
Sure.
Yeah, guys, just quick, I know everybody wants to go, and, we get over, our disease and our fight and everything that's going on, and then sometimes we don't realize some of the long-term side effects. And I found out one of mine recently this year. I'm 52 years old, and I should definitely not need a hearing aid at this point. And we're going to be doing a webinar on Thursday. You can go to teamtony.org, and David will also send out a link. We're partnering with the Silverstein Institute and long-term side effects of chemotherapy, radiation, and it's going to be really interesting. I hope you guys will come out and listen to it, watch it, and I walked to work the other day and with my new hearing aids, and I don't recall hearing more birds on the way to work. Went to a movie yesterday, and a completely different experience. So please come out on Thursday and spread the word, and just to see what's going on and why.
I'll get a notice out to you guys.
Okay, I think patients said.
Thanks, everybody, for being here.
Yeah, thank you, Doctor.
Thank you, Doctor.
Best office I'm at 4 days.
I know.
Yeah,
Thanks.
1 day a week, and the other ones I cover.
Thanks, Edward.
Yeah,
Good question.
yeah.
Good question.
Yeah, because I'm right at that critical point.
Thank you very much.
That's accurate.
Oh, okay. Yeah, okay. So, yeah, just give a call from you.
Yeah,
Okay.
yeah, thank you so much.
All right,
I really
nice to meet
appreciate it. Also, thanks for that.
All right. Thanks, you guys.
Thanks, Doctor.
Nice seeing you. Thank you, Tony. That's fine.
Bye.
Really good. All right.
Come by and come back again.
Yeah.
Hey, our space is your space, so.
I appreciate that. Thanks a lot, you guys.
Thanks again.
Yeah.
Take care, Doc.
Bye, gentlemen.
My goodness.
Didn't have a, when you said Dr. Ackley, he's my doctor too.
Yeah, he didn't seem to,
Yeah,
be
he's-
thrilled with that.
Yeah, and I'll tell you maybe why. Because he's my doctor. And so he at first proposed seeds and radiation, because I'm kind of favorable intermediate risk. And Dr. Ackley said, oh, I'm not a fan of seeds because it can migrate. So I told him, he said he doesn't know what he's talking about. So I think because actually there's.
It doesn't propose the seeds, yeah.
Seeds.
It turned up myself here.
Well, that's the thing, I don't know enough about the seeds to really, I mean, it's something I have to explore still at this point, but.
He wanted to do both, and I don't know, after he started talking and stuff, and finally just said, do the external, you know.
I did seeds. I got seeds.
This part of the world.
You still have seeds in there, yeah.
Oh,
You don't know, you don't
Did you
know.
find any adverse side effects of it?
Hesitation.
How long ago did you do that?
5 years.
And I know she.
I do follow up,
When I left.
5 years ago, yeah. It was like 15 minutes in the office.
Did you have external radiation too?
Yeah, oh, yeah.
Maybe I should have done that.
Yeah, I did 28 days of radiation, and I did hormone therapy for about a year. And the seeds were done right after the radiation.
and the seeds were done after the radiation, I thought they would be doing in conjunction.
Well, it's almost in conjunction. It was like, I don't know, I think within a week or within a few days after I completed the radiation. Yeah. Some people have done it before.
Or he says now they do it first and then do the radiation.
Yeah, I've heard that.
Well, I mean, it seems that the seeds would somehow, there's an interaction there between where they're focusing the radiation when they're.
Well,
taking the seeds.
the seeds just kind of continue the radiation or provide more dosage.
Mhm.
But for a longer period of time, they stay in your system.
Yeah.
For a while, for a year or two.
Yeah, I was just always worried about whether the seeds migrated to, or whether they were
Yeah.
cancerous and further down the road.
I have heard that, but I've never heard it.
Did
I
you
had
do-
radiation.
You should have asked him about that.
I had radiotherapy.
Did you?
Yeah.
But where? Not in your prostate, in the brain.
Mhm.
Yeah. Now, did those
Same
seeds,
process. What?
Same process.
They injected for me, it was a radioactive isotope.
Yeah.
Mice antibodies.
And did you do that after radiation, the seeds, or?
I had radiation after that. I had the external beam radiation after that. I had that. I had the radiotherapy. 2 years of chemotherapy, external beam radiation, and then 3 years of chemotherapy.
A lot to process. I'm wondering if prescribing PSMA test, if that's something that my urologist can interpret, or if I should just go to an oncology doctor to get them to interpret what the PSMA test
who you got now, a urologist?
is. Acne right now.
Oh, Ackley, yeah, you're saying.
Yeah.
What was his reaction to Ackley, Sylvester? She said it was.
It was a little cold, I mean, just, a little cool.
I can't figure that out. I thought they were
Yeah.
close to the line.
Yeah. Well, I have to investigate all the evidence, but I don't know if Acme will be able to, I guess I would imagine that he should be able to interpret the CSMA test.
I would think,
I don't
yeah.
see why not. He didn't recommend
Can
it.
you help, Tony?
No,
I was curious,
I got it all.
I was curious that he didn't recommend it, you know, so that's.
You're a guest, I got it.
Tony, this should be recording, you know, or
Yes.
what do you call it? But I'm not seeing the little page that I should. Meeting,
Probably,
little
stop.
meeting controls.
So that's where it's recording right there.
So it's still recording us. or
Yeah,
just-
I would probably stop and share.
Oh, stop.
Stop and share, yep. And then,
Recording still, I'll be darned, yeah.
Yeah.
Pause recording.